Okay. How long has he been like this?
Half an hour or so.
Half an hour?
He's gotten a lot better.
Okay, half hour. What prompted you to call us?
I came into the room and he wasn't doing anything, and I only found one of these shoes, and I know that there'd been two before, and I picked him up and he was gagging. And
Did you look in his mouth?
I picked him up and I looked in his mouth. And I put my finger down there and I tried to get something out, but nothing would come, and he just kept gagging.
So was he able to cry? Like this kind of noise?
No.
Okay. Did he turn blue at any time?
No, he was like turning a really bright red.
Okay. How long was he really, really red and gagging for?
Gosh,
So
seems like forever. A couple minutes, 2-3 minutes.
Okay, a couple minutes. And then so over the last 30 minutes since we arrived?
He's been getting better.
Okay.
I didn't know whether I should call, but
Oh no,
I just
you did the right
didn't know.
thing. What we'd like to do is put this, just sort of have you hold this near his face. It's just oxygen, and it'll just sort of help. Hang on right here. Okay. That's that. Good. What I'd like to do is put his bib down on his overalls and just listen to his lungs. Okay. So if you could help that, because normally
Okay.
we could use a little Nancy. Okay. Want me to hold that on there? Here we go.
You like that, don't you?
Okay, bud. Okay? It's nice and warm. What do you think?
Take it.
There you go. You can hold that right up to his nose. Okay, one more. Right. Ooh. That's good.
It's okay. It's okay.
He's passing air, but I think he's got like an obstruction on his left side.
Left side?
It's gonna be okay.
I think he'll be fine, but I'm not sure if he swallowed the shoe or what, but he's passing air, but I think we should go to the hospital. As a precaution, mainly, but I think we should go to the hospital.
This program is mainly about handling respiratory emergencies when the child already has a problem. Usually we think about EMS responding to a problem that already exists. And this may sound a little strange, but it's at least as important to think of EMS as a preventive organization. As a pre-hospital care provider, you have an opportunity to make a significant impact on the safety of children in your community. You also have a responsibility to do so. You'll have professional and social reasons to visit places where kids live and play. The more aware you are of ways to prevent childhood illnesses and injury, the greater impact you can have. This little guy is 15 months old. He learns by doing, by discovering, by accumulating experiences. It's natural for him to be this way. The more he does, the more he learns. Usually, mom and dad are there to keep him out of trouble, but not always. The typical household, even with the best of intentions, is full of hazards. The combination of this explorer and those hazards can be dangerous. As we've said before, kids are different. For instance, their airways are built differently. They're more susceptible to infection that can compromise their respiratory system. Their behavior and understanding aren't as mature as most adults, so they tend to get into trouble. And they can be harder to manage medically. Fact: in children, the leading cause of preventable death is failing to manage the airway properly. Fact: the airway is the key to success in pediatric resuscitation. Cardiovascular problems can often be treated with oxygen and ventilation alone. The respiratory system is to pediatric emergency medicine what the cardiovascular system is to adult emergency medicine. Ventilation depends on mechanical movement of the lungs The diaphragm is the main breathing muscle, but it can be assisted by so-called accessory muscles of respiration when needed. Those include the muscles between the ribs, the intercostal muscles, the ones up around the neck, and even the mouth and nostrils. All those muscles can contract and relax to pull gases in and out of the lungs. The upper airway consists of everything from the mouth to the trachea at the level of the sternal notch, here at the top of the sternum. The upper airway includes three important landmarks: the epiglottis, the larynx with its vocal cords, and the trachea. The lower airway consists of the main bronchi and smaller bronchioles that are formed by the repeated dividing of the larger bronchi. The object of ventilation is to get air in and out of the alveoli. The lungs have thousands of these tiny sacs that hold a mixture of gases. And surrounding each of the alveoli are capillaries carrying blood.
How long has he been like this?
Half an hour or so.
Okay, two main messages. First, your goal when you assess the child with respiratory problems is figuring out if the child needs life support. Here's the other main message. The way you approach your patient and the general situation is a critical factor in how successful you'll be in managing the patient and the situation. Know that when you deal with children, there's always the potential for panic. Panic on the part of the child, the parents, and EMS providers, including you. The child's level of consciousness is a good measure of respiration. Agitation and irritability may indicate low oxygen in the blood getting to the brain. On the other hand, lethargy and decreased responsiveness can also accompany low oxygen. Respiratory distress is seen during the early stages of a respiratory problem. The kinds of things you'll see are mainly a result of the child's body compensating for the problem. You'll see an increase in respiratory rate, use of accessory muscles, plus an increase in heart rate. You can think of respiratory failure as an end stage of respiratory distress, regardless of what caused it. It can develop rapidly or take hours. The clinical signs are mainly due to the tissues having too much carbon dioxide and not enough oxygen, a decreasing level of consciousness, abnormal heart and respiratory rates, and low blood pressure. Note that with respiratory failure, children can have abnormally low heart rates and respiratory rates. These are ominous signs, since they indicate the child is no longer able to keep up with the situation. If this situation is not corrected, the result will be cardiovascular collapse and complete cardiopulmonary arrest. Upper airway obstruction can involve the tongue. The tongue can prolapse or fall back into the airway, which is a common cause of airway obstruction. Note that the tongue isn't swallowed the way some people say. Rather, it happens when a child has a decreased level of consciousness. The jaw relaxes and the tongue falls back so that it blocks the airway. Note also that it's easy to recognize and correct this problem. You just have to be aware that it can happen. Then there's the epiglottis, which, as you know, sits just above the larynx and the trachea. It can get inflamed, a condition called epiglottitis. When it swells up, it can really obstruct ventilation. The larynx, vocal cords, and the trachea. Those can get inflamed and swollen, also obstructing ventilation. The condition involving those three is called croup. Here are the retractions. See how the skin depresses as the child breathes in? Look around the clavicle. Below the sternum. And between the ribs. Stridor is a breath sound that can often be heard without a stethoscope. It's a higher-pitched crowing or barking sound heard mostly as the child breathes in. It's mainly a result of narrowing of the airway around the larynx. Listen to this child with inspiratory stridor.
Did they check his ears
all
today?
day. Yeah, they said they were fine.
So when
Yeah, he's not feeling well.
Asthma causes narrowing due to contraction of the walls of the bronchioles and swelling from inflammation. Infection can cause inflammation of the bronchioles, called bronchiolitis, same deal. The inflammation causes swelling of the bronchial walls. The bronchioles also can get plugged with fluids like mucus or pus, things that go along with inflammation or infection. Here's what wheezing sounds like. Sometimes you need a stethoscope, but it's usually easy to recognize. It's generated by air passing through a narrowed airway, like when you suck through a pinched straw. Wheezing can tell you a lot about the severity of your patient's obstruction. With mild obstruction of lower airways, you'll only hear them on expiration. As the obstruction gets worse and the airway narrows, you'll hear wheezing on both inspiration and expiration. Finally, as obstruction of an airway becomes complete, no air is passing and there are no wheezes, the so-called quiet chest. Look for signs of increased work of breathing. These include retractions and use of accessory muscles. You may also hear a grunting noise as the child breathes out. This adds pressure to keep the alveoli open. The position that the child takes can tell us a lot. What some call the sniff position means the head is held in a neutral position with the jaw thrust out. This straightens the airway to open it as much as possible. You'll see this with severe upper airway obstruction, particularly with epiglottitis. In the tripod position, the child is sitting up and leaning forward, supported by his arms. This gets the accessory muscles working as much as possible. The patient is often in severe distress. The child's respiratory rate should be measured by observing the bared chest and abdomen. As you know, the normal range for respiratory rate changes with age, as shown here, but a rate over 60 breaths per minute is abnormal in any patient. We can assess patients in the field to put them in general categories, enough to make good decisions about initial treatment and transportation of those patients. This makes the job much simpler and more efficient, since we don't get hung up on getting an exact diagnosis.